She's from Indonesia.
That's my name. Thank you very much for the NIC organizing. I guess during my 4-month stay here in India, this short notice keeps me surprised because I just knew that I have to present this case like 5 minutes ago. So we have a case of massive bilateral DVT, and on the basis of Firko's triad, the DVT may occur, and the unprovoked DVT in young adults is an unusual phenomenon, and it is associated with significant morbidity and also mortality. So we have a case of a male. He is quite young, 34 years old, presenting with a bilateral leg swelling. He is active worker, ambulatory. There was no history of malignancy, and there was no history of previous DVT. So just 1 week before his admission to our hospital, he was admitted to the other hospital with massive pulmonary embolism. Sorry. What happened? So he was admitted in other hospital with massive pulmonary embolism and left DVT, and in this hospital he was treated with systemic RTPA infusion or thrombolysis, and the hospital implanted an IVC filter. So just 3 days after his discharge, he came to our hospital again with a recurrent, this time is bilateral leg swelling. So in any case, this 14 days after the first symptom, he came to our hospital with a recurrent DVT. There was no major issue in his physical examination. He has no dyspnea, and then only the bilateral leg swelling, and the right-sided is more than left-sided. Echocardiography was normal. We couldn't find any signs of pulmonary embolism or pulmonary hypertension or the RV failure. Okay, so this is the initial peripheral venography. We use the right femoral vein access, and with the multipurpose catheter, we see a massive thrombus in the pulmonary, in the femoral vein, in the right common iliac vein and external iliac vein. And also, if you see the left-sided, the thrombus goes up into the IVC filter, and the IVC filter was totally occluded. So, next. So we advanced the catheter using just a normal thermowire into the pulmonary, the catheter into the pulmonary artery, and we confirmed that there was no appearance of the thrombus in bilateral, in the main pulmonary artery, in all the bilateral pulmonary artery, all the branches. Next. So we decided, based on this massive thrombus in the right-sided vein and also the occluded IVC filter, we decided to perform the catheter-directed thrombolysis using a multi-site holes. Actually, we did it manually for the GR4 French catheter, and we delivered the alteplase continuous infusion initially with 2 mg/hour into the thrombus area, and we evaluated on 12-hourly basis. So we modified this catheter into the place where the most thrombus is. In 12-hourly basis, we continue the alteplase infusion. And after about 120 milligrams during this catheter-directed thrombolysis, we could see that there's a lot of improvement. And afterward, we can see that the complete recanalization of the right-sided veins and also the complete recanalization of the IVC filter at that time. And again, since he has bilateral DVT, so we have to observe, we did a venography for the left-sided veins. We advanced the catheter using, this time we used the help of the more stiffer hydrophilic wire and advanced the catheter into the left common iliac vein, and we observed there's a massive thrombus in the left common iliac vein and the left external iliac vein up to the mid of the femoral vein. And again, in this time, we did a similar approach for the catheter-directed thrombolysis using the multi-site holes again. And this time, we did the alteplase continuous infusion of 1 mg/hour, and we did a 12-hourly basis evaluation. So in each series of evaluation, we see improvement or slow recanalization of the vein. And then after a total 160 milligram of the continuous infusion of alteplase within about almost 6 days at that time, we see a complete recanalization of the left-sided vein also. And a final angiography showed apparently that there was a compression of the left common iliac vein that shows it apparently a May-Turner syndrome in this patient. So what we decided next was that we dilate this left common iliac vein with a balloon of 10 into 60 millimeter, and then we implanted the self-expandable stents of 14 into 80 millimeter, and we deployed of the landing zone just distal of the compression, and 1 to 2 millimeter just proximal of the left common iliac vein and the IVC junction. So after the stent placement, since we saw there's a slight unsatisfactory result of the flow of the dilatation, so we perform again the post-dilatation using the similar balloon. And then after the final result of venography, we saw a very good satisfactory result of the left common iliac vein flow up into the IVC. So again, our question is, since our patient has a pattern of anatomical abnormality, so what happened with the right-sided DVT in this patient? So based on this clinical trial, we just evaluate the thrombophilia factors, and this patient was found to have a methylene tetrahydrofolate mutation, which later we found that he had an increase in homocysteine level. So this is actually an enzyme that may inhibit the homocysteine metabolism, so the enzyme is increased. And in South India, knowledge also has reported that the mutation in these genes may lead into the increase of the thrombus, systemic thrombus, or even the vein or arterial thrombus. And in men, it will increase the risk of 9.35 of ratio increased risk in thrombosis. So at the final follow-up, this patient has a very well clinical condition. He had only mild edema on both legs. The outpatient follow-up 7 days after post-discharge, he's a very good clinical condition with complete resolvement of the edema. And we maintain this patient in dual antiplatelet and also new oral anticoagulant. So the take-home message in this case is that a massive VTE or DVT is quite rarely occur in young person, and we have to think anatomical abnormality first, as well as the defect in thrombophilia factors that might occur as you saw in this case. And catheter-directed thrombolysis therapy for acute DVT may perform, followed by venous intervention. And we have to evaluate with a careful monitoring, because what we did here, we did a quite prolonged infusion of alteplase infusion. And some bleeding may occur, but in this patient we didn't. So we may did it persistently, and we have a very careful monitoring and a clinical decision for this patient. Thank you very much.
How long do you propose to use anticoagulants in this patient?
We did this case in February, so up to now we still give this patient in double antiplatelet and oral anticoagulant. So actually for the triple entry thrombus for vein stenting, there's no guideline yet. But for arterial and for coronary, we had a guideline for double antiplatelet and vein. But we observe carefully this patient, and up to now we still give new oral anticoagulant. The thing is that he had these risk factors for defect in thrombophilia factor. So we have to, based on this case, I think we have to give the new oral anticoagulant, but we may have to think to decrease the antiplatelet for the patient. So probably one antiplatelet and one new oral anticoagulant. And we have to evaluate later, after 6 months or 1 year, then whether we have to decrease the antiplatelet or not.
What catheter you used for perfusion? What catheter you used? CDT?
Oh, for the CDT, we use the Jaskin Right. For the initial evaluation, we use the multipurpose.
Multiple sidewalls catheter you found?
We did it manually. We did the holes manually, actually. So it's not a
Endole or multiple sidewalls? which catheter you use? Endo or multiple side holes?
It's a usual GR catheter, but we did put the hole
Manually.
intentionally, yes.
Because,
We did like 4 holes in 1.5 centimeters difference.
No, actually, if you take a Cook perfusion catheter, it will have almost 10 centimeter. You will have multiple side holes. That is the ideal catheter for CDT. So, pass the wire up to the popliteal vein, just put and then infuse. So that another thing, sometimes what a massive thrombus is there, that the pulverizer of the thrombus, use mild dilatations with the balloon, subsequently put, it will lead to effective more thrombolysis.
Thank you, sir. Thank you.
Next one. Dr. Viveka Kumar, LV pseudoaneurysm, a percutaneous therapeutic possibility. I think not there, I think. LAD CTO in a left main occlusion and STEMI, acute STEMI. Is he there? Is he there? Not there, I think. Snapped stent balloon shaft during PTCA retrieved successfully percutaneously. Dr. Envo Bansal. I think not there. Acute ischemic stroke after primary PCA. Intracoronary thrombolysis in young patient. Double whammy. Dr. Pankaj Jariwala. I think okay. No. First time thinking.